IMA మరియు ఆప్నా వారి ఆధ్వర్యంలో వరల్డ్ లూపస్ డేని పురస్కరించుకుని లూపస్ వ్యాధి గురించి విశ్లేషిస్తున్న డాక్టర్ దామోదరం, రుమటాలజిస్ట్ డాక్టర్ నాగజ్యోతి, డాక్టర్ సునీల్ లూపస్ వ్యాధి గురించి విశ్లేషించారు. ఈ కార్యక్రమానికి ముఖ్య అతిథులుగా శ్రీహరిరావు, ఏపీఎంఎస్ చైర్మన్ డాక్టర్ సుబ్బారెడ్డి, ఆప్నా రాష్ట్ర అధ్యక్షులు పసుపులేటి హరిప్రసాద్, హస్తకళల అభివృద్ధి కార్పొరేషన్ చైర్మన్ తిరుపతి అధ్యక్షులు ఆర్ఆర్ రెడ్డి, ఆప్నా తిరుపతి అధ్యక్షులు డాక్టర్ రవిరాజు, శుభోదయం హాస్పిటల్ అధినేత డాక్టర్ దామోదరం, IMA తిరుపతి కోశాధికారి డాక్టర్ రెడ్డప్ప, తిరుపతి సెక్రటరీ డాక్టర్ మారుతి తదితర డాక్టర్లందరూ పాల్గొన్నారు.
And then gene that code for variants of auxins, that is phagocytosis, impaired phagocytosis. We can see the immune complex are deposited in the kidney. So why our body could not able to remove that immune complex? Because of the defective phagocytosis. And then genes for complement receptors, antibody receptors, and sometimes the cytokine signaling is overactive much than the normal. Especially we have called interferon. So this interferon expressor genes. The interferon is very important for the viral immunity. So most of the SLE is activated. One of the most important environmental risk factor is the viral infection, especially Epstein-Barr virus. Genes that code for Fc gamma receptors. So this Fc gamma receptor is also part of innate immune system. So that is important for the removal of the immune complex. So what I was saying, the kidney deposition of the immune complexes, filter damage. So there is a defect in the phagocytes and the removal of the clearance mechanisms. So that leads to the, so the more the site, the more the gene is active in the lupus and the interconnections. These are the environmental risk factors. Estrogen. Why estrogen? Estrogen stimulates B cells. It activates B cell activating factor. That's the reason why females are more prone for autoimmunity compared to the male patients. Cigarette smoking, silica and mercury infections, and even repeated urinary tract infections. And tuberculosis. Tuberculosis we see very common in lupus patients. Before they present lupus, we have seen many patients having tuberculosis and some drugs and UV light. So because of the checking failure, so what is happening? Antibodies to the nucleus. That's what we call as antinuclear antibodies. Antibody to the cytoplasm of a cell. So antibodies to cell cytoplasm, anti-Bo and anti-La antibodies. Then DNA is over, cytoplasm is over, and then we have cell-specific antibodies. So for reason for what is the hair loss? Antibody to the hair follicles. Okay, and then antibodies we have seen where and antibodies to red blood cells, platelets and lymphocytes, and what not. Antibody to serum constitutors. She has explained Adam's deficiency and then phospholipids. Where it is present in serum. So it affects the nucleus, cytoplasm, cell and serum. So all the different components are there. So depending upon the type of the component that is lupus, no. DNA can be positive in healthy people. Unless they have a symptom. The first antibody that is going to positive in lupus is anti-Rho and anti-Lo antibody. After that, anti-dsDNA or any other antibody forms. You can, by giving rituximab, you can remove anti-dsDNA. By giving steroids, you can decrease the titer of dsDNA. But we cannot decrease the titer of anti-Rho antibodies. So when there are newer therapies, if you are decreasing the titer of anti-Rho and anti-La antibody, that means you are curing the lupus. So we have newer forms of therapy where we can cure the disease. I will tell you later. So SCLA is a multi-system disease. It can have a very mild disease with only mucocutaneous manifestations. And this is the area we need. These patients are our goal. That's the reason why we are conducting this meeting. We have done various lupus walks and patient awareness meetings. When you have a mild disease, 100% they won't go for a major organ disease. And we have a severe life-threatening disease with multi-organ involvement, as explained by various speakers. Okay? So constitutional symptoms is in 90%, that is fatigue, malaise, fever, weight loss, skin involvement, mycolic solid, acute, subacute, chronic lesions, photosensitivity 90%. And you have photosensitivity and joint pains, why not? It's SLE. You have to refer that patient. Oral ulcers and nasal ulcers, painless and gradual. Breaking lupus cells. Cells are very brittle because of antibodies to hair follicles. Raynaud's phenomenon. In our Indian settings, because of the hot climate, many people doesn't have the classical features. Even certain symptoms of tingling, numbness, especially exposure, it changes three ways. That's very rare. But we have seen, but any tingling, numbness, especially exposure to cold atmosphere, so we need to think about lupus. We have diagnosed recently, Raynaud referred one patient with Raynaud's phenomenon. Suspect he done three digits. Only the Raynaud's phenomenon he was referred to me, and he has got a full house effect. All antibodies are positive. And we immediately started microfilm Moftil and Tadalfil, patient complete result. So that type of patients we need. And libido reclams and vasculitis. Vasculitis definitely it is life-threatening unless it is a very little cutaneous involvement. Coming to the arthritis, it can be non-erosive, like rheumatoid lupus, it is non-erosive. But we have a overlap, SLA and RA overlap. So where you can see the lupus and also the destructive. Then we put them as the SLA and RA overlap. And that's Jacob's sarcopathy. Because the another term for lupus or any other form of rheumatological makes it connective tissue disease. Because this affects the ligaments. So you can see ligament laxity and deformity, which are reversible. But it
is previous tissue, very highly vascular tissue. So quite frequently the vivid tissue get affected, which leads to the inflammation, uveitis, which leads secondary glaucoma. So this is quite common in SLE patients. And this is very important. This is the second commonest cause of blindness in lupus patients. You can see very clearly how this retina is involved because of vasculitis. Retina has the blood retinal barriers, inner retinal barrier, outer retinal barriers. So when the vessels get affected, these are areas of retinal ischemia caused by small retinal vessel occlusion. This exactly means vascular occlusions. Central retinal vein occlusion can occur, central retinal artery occlusions can occur. Sometimes patient may undergo retinal detachment, severe exudate yawning. These are the conditions linked to the retina. Because retina is a more vulnerable structure to get affected, you get the typical side effect of hydroxychloroquine is called bullseye macular. You can get the pigmentary changes around the macula. Exactly, it looks like what we call the bullseye maculopathy. And this is the early symptoms of these patients will have. Patient may not able to read the small prints because the central cortex is affected, so he is not able to read the small letters. In
pediatrics also, the children who present with nephrotic, nephritic or a connective tissue disorders, 20% incidence of SLE can be there. So lupus nephritis occurs in 50% of patients with SLE. Most common cause of renal involvement, but not the only cause. So even in SLE, the renal involvement may be due to causes other than SLE. So renal biopsy is a mandatory phenomenon. Men with SLE tend to have a more aggressive disease. Without proper treatment and diagnosis, around 10 to 30% of patients with lupus nephritis may progress to ESRD, which is much more significant. Lupus nephritis can present as a part of systemic lupus or renal limited lupus. It can present simply as asymptomatic urinary abnormalities or a nephrotic syndrome where you can see nephrotic range proteinuria. In this syndrome, the patient usually presents with facial puffiness, sputum edema, frothy urine on and off, which develops over a period of weeks to months, and no active urinary sediment. That means the patient doesn't present with gross hematuria or microscopic hematuria. Renal impairment may or may not be present. And coming to nephritic syndrome, here the patient presents in weeks to days with pedal edema, sometimes color-colored urine, and with or without renal impairment and hypertension, and rapidly progressive renal failure. This is the most important and most severe form of renal involvement in lupus, and rapidly progressive renal failure. So this is the rapid progressive renal failure is a syndrome which needs to be diagnosed as early as possible. And next one is the most rare but most severe form of lupus is vascular lupus. It presents as usually thrombotic microangiopathy or antiphospholipid antibody lupus. So this is a case scenario where a 30-year-old woman with a known history of SLE associated with malar rash for proteinuria was referred to a nephrologist for evaluation of proteinuria discovered by protein analysis. So what investigations do we suggest? So all these 4 investigations are mandated. Just a urine dipstick is not sufficient to grade the proteinuria because urine dipstick measurements will vary by a specific gravity of urine. When the urine has low specific gravity, it may have a false negative results. When urine specific gravity is high, it may have false positive results. Though dipstick is positive, it should be quantified. There should be quantification of proteinuria as 24-hour urine sample is very cumbersome to collect. You can even go for a urine spot protein creatinine ratio. And even in urine dipstick, if the blood is positive, it could be false positive or maybe this can be differentiated by dysmorphic RBCs, signifies renal inflammation. So presence of WBC Cas doesn't always indicate an infection. It can also indicate a renal inflammation such as glomerulonephritis. And the other thing is serum creatinine or GFR estimation. This is the most important thing. Serum creatinine estimation can be sufficient in adults, but in pediatric cases, a GFR estimation is must and should. So, when do you suspect a lupus nephritis? After this, getting these investigations done. So, proteinuria greater than 5 milligrams per day, nephritic urinary sediments like dysmorphic RBCs, RBC Cas, WBC Cas, especially if combined with evidence of proteinuria and decreased renal function. So, after this, what do you do? The gold standard for diagnosis and classification of lupus nephritis is ultrasound guided.
Mesenteric vascular gas is a rare formation when the patient have a mesenteric ischemia. This jejunum and ileum are most commonly affected, with involvement being a segmental or multifocal rather than restricted to a vascular territory. And other thing is barium studies also we can do whenever the patient have a like abdomen distension or having a recurrent vomiting. So localize the exact stricture area we can study with the barium studies. They will show the terminal ileum IC valve involvement is more common. There's almost like since MBBS time we have the dilemma. So once we see the ulcers in the ileum and Crohn's, there is a dilemma between whether it is a Crohn's or tuberculosis. But we should not forget this autoimmune disease like SLE. So the biopsy is very important. Pathologists also should be aware of. We have to give the complete details of the patients. If the patient we are suspecting an autoimmune disease by patient having a joint pains or skin rash, it is both ways. One is the IBD with extra-intestinal manifestations. Other thing is extra-intestinal manifested disease, that is systemic disease like SLE causing a bowel disease. It is very important to give the clues to the pathologist to reach the diagnosis. And if you see the biopsy in SLE related, then only the pathologist will put some concentration to check these findings. But in the Crohn's disease, if we see there will be a transmural inflammation with non-caseating granulomas, but there won't be any vasculitis or venulitis in the Crohn's disease. Tuberculosis, of course, it is a necrotizing granulomatous inflammation. So this was one case report which was like lupus nephritis manifesting palisading as a Crohn's disease. So this patient was having a typical findings. See, these are what all I told. This is a target sign causing the bowel wall edema, giving a target sign appearance on the CT, and this is the combing sign. So the numerous proliferation of the mesenteric vasculature giving a comb-like appearance. And this is on laparoscopy. You can see here that brownish is because of the ischemia. And this was during laparotomy. You can see that segment of jejunum which was taken out. It's completely aperistatic, and that valvular convent is structure, everything got disorganized, and this segment was resected in this case.